Hi guys. Okay, so we are going to do case study 51 and then after that it's going to be 52, Addisons and cushions. Okay, so let us go over like a quickie for the two and oops. Okay, so let's take a look at the two. What are we talking about? So we have the hypothalamus, we have the anterior pituitary, then we have the adrenal cortex, and I'm gonna have to draw a really big adrenal cortex. I'm gonna make a teeny little adrenal medulla. Okay, so this is the medulla, this is the cortex. The hormones that are coming from the hypothalamus are called the CRH, right? CRH stimulates the release of ACTH, adrenocorticotropic, adrenocorticotropic hormone, and this is corticotropic releasing hormone, corticotropin releasing hormone. Sorry, and then that acts on the cortex, the adrenal cortex, to release aldosterone, cortisol, and testosterone. Cortisol is key in controlling this pathway. Just remember that when cortisol is high, it will cause a feedback to both the hypothalamus and to the anterior pituitary to trigger those hormones that are being released to be low. So cortisol is key to turning this pathway on or off. Aldosterone, we don't care. Testosterone, we don't care. Doesn't respond to those two, it responds to cortisol release. So this pathway is a little bit complex, so I'm going to simplify it down to A, C, T. I'm going to say there's a couple of enzymes that cause it to either go one way or the next. Okay? And so we're going to focus on cortisol. Notice when you get stressed, you tend to eat a lot. It's a little bit of hyperphagia. Okay, so cortisol. A little bit too much cushion for the pushing. Cortisol, right? So when you get stressed, you'd see a lot of weight gain. The typical image that you have with someone who has Cushing's is tranquil obesity, purple striae, moon faces, right? There's like a fatter face, buffalo hump. You're going to have, depending on how long, you might have bruising in the skin. You might have like bone density problems, the same problems that you would see with administration of cortisol, like steroids, over long-term use is the same kind of presentation you would find with these patients, right? They mimic one another. Why? Cortisol, when you give it, you administer it, they call it iatrogenic. So you could have iatrogenic Cushing's, in which your patient comes in for transplant, right? They have the transplant done, you give them immunosuppressants, cortisol-like steroids, and the side effect of that is Cushing's syndrome, right? Whereas Cushing's disease could be something going on with the cortex itself. So too much cushion, a little bit too much cushion for the pushing. But now if I don't have enough cortisol, then I'm lacking. And if I'm lacking, then I need to add. So let's do two scenarios. The first one is Addison's. Now with Addison's versus Cushing's, which one do you think is going to be slender? Probably Addison's. Which one do you think is going to be a little puffy? Cushion, right? A little bit too much cushion for the pushing. So let's say that in addition to stimulating the anterior pituitary to trigger the release of acetylcholine, this guy up here, corticotropin releasing hormone, will actually also stimulate MSH. And MSH stands for melanocyte stimulating hormone. They stimulate the cells in the skin to cause pigmentation and darkening of the skin, right? So it causes you to become darker. Darker where? Everywhere. Inside of mouth, gums, palms of hands should be different than the back, right? You always see a difference in the back and the front. So if they have looks darker on the hands, looks darker on the gum lines, then maybe they have Addison's, because Addison's is a lack of cortisol, whereas Cushing's is an excess of cortisol. So let's go over the case study really quickly. This is your background for understanding it, and here we go. So first one, Addison's. I've been feeling weaker, more tired over the past 4 months, but it's taken more of a severe turn for the worst for the last week. haven't been able to enjoy any outdoor activities with my family, but for some strange reason, I've been getting an unusual tan. Wow, didn't we just say that this person, if they have Addison's, there's a decrease in cortisol. I will show you. This decrease in cortisol will increase CRH. Increase in CRH will increase ACTH, but oh my goodness, something is broken in here. So no matter how much I increase it, it cannot trigger more cortisol. Something's wrong with it, right? That's why it's broken. But a side effect is that even though this isn't working, there are other hormones being stimulated. These hormones release and trigger the pigment in the skin to become darker. That's why she has the suntan, right? So now we have CK, 48-year-old white woman who presents to her sister's PCP with loss of appetite, progressive fatigue, mild nausea for 5 days. CK and her husband are visiting from Wyoming for 2 weeks, but not felt well enough to bike, hike, or climb for the past week. Her sister has insisted that she see a healthcare PCP or provider. Appendicitis treated surgically 10 years ago. Seroconverted to PPD 6 years ago, treated for 12 months with INH. Pernicious anemia, 5 years, so you know that she has some blood work issues, right? Hypercholesterolemia, times 1 year controlled with diet and exercise. No family history of cancer. Father died from cardiac arrest, age 65. Mother currently resides in nursing home. Consequence of CVA or stroke, right? Has rheumatoid arthritis. Her 2 sisters, Hashimoto thyroiditis, so thyroid dysfunction. They're probably going to try and rule that out with her. Graves' disease, another thyroid dysfunction. And what are we talking about? We're talking about the adrenal glands. Do you know where these guys are? So we know that the thyroiditis is up here, right? But where do you find the adrenal glands? They're on top of the kidneys. So you take your fist and you make a little thumb and you go pick, 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 pick. So the adrenal gland is sitting right on top of the kidney, and the kidneys aren't they located about the level of T12 and L1, L2? So right in the back, right? So when you do like a costovertebral, um, you hit the backsides test for UTIs. That's about where the level is for the kidney. So thyroid up here, kidneys down below. So here we go. No family history of cancer, and we went through that. Graves' disease. Has one brother, 53, alive and well. And then born, raised Dallas, Texas, owns, manages bed and breakfast with husband. Husband overwent triple bypass and then drinks wine with dinner occasionally, denies tobacco use. Loves traveling, camping, hiking, climbing, walks in treadmill 3 times a week. So she's very healthy, right? She's cyanocobalamin is B12, right? So we know that B12 deficit with her pernicious anemia. What does that mean? Pernicious anemia, this is not going to be tested on, just doing a little review for you guys. So in the stomach, you have something called intrinsic factor. Intrinsic factor helps to absorb in like the terminal ileum, the small intestines, helps to absorb vitamin B12. Now, if I cannot absorb B12, I can't make red blood cells. If I can't make red blood cells, I'm going to end up with anemia. So that type of anemia, because of this problem, is called pernicious anemia. And so you're going to have to replace the B12 with a drug, and that drug is called cyanocobalamin. So here we go, every 15th month, because this guy can be stored in the liver. Aspirin she's allergic to. Bactrim DS or even Septra DS, that one she's allergic to. And then we have negative for chills, okay, positive for weight loss, positive for salt cravings. Oh, yeah, why salt cravings? Okay, one of the issues that she's kind of having is we don't know where the dysfunction is. So if the problem is here and here, and I lack cortisol, and I also lack aldosterone, then the potential is, remember aldosterone, you guys might not, it's been a while, I'm sure, but aldosterone comes from the cortex and it helps to reabsorb salt, and wherever salt goes, water follows. So it helps to maintain blood pressure by reabsorbing salt. Now, if she lacks aldosterone, is she reabsorbing salt? No. If she doesn't have salt, is she going to crave it? Yes, so she's craving salt. Just an indicator that she has dysfunction in the adrenal cortex that's causing loss of aldosterone, loss of cortisol, and we'll see more symptoms. So we got several bouts of dizziness. Well, she's hypotensive, right? Because she's lacking aldosterone, having salt cravings, low blood pressure. We'll probably get to that later. A few aches and pains, prominent for tanning of skin. We already went through the patho of that. And she denies being out in the sun. They have to tell you this so that you're not assuming that it's a suntan. Tired looking, tan Caucasian woman, no apparent distress, appears stated age. Vital signs, let's see. Blood pressure within normal, maybe on the lower side, right? But then that's for sitting, and then standing, she's hypotensive. Okay, respiratory rate on the lower side, no infection, 5'6", so healthy individual, right? Intact, warm, very dry, normal turgor, subnormal turgor, a little bit on dehydration side. But we already kind of are familiar with that because anywhere salt goes, water follows. So if she's losing salt because she's not reabsorbing it, she's going to be dehydrated. Generalized tan, we know indication of Addison's, even at sites not exposed to the skin. So we already got this. And then Perla, anything else that we can do? We know that she's probably going to have, let's see if she has very dark areola. This is just indicating the same thing, right? This is indicating that she has excessive MSH release, which is darkening everything in the body, right? Areola are not left out as an exception. And then we already know dry mucous membranes for dehydration because of the lack of aldosterone. So she has two things going on, or three. She has lack of cortisol, she has lack of aldosterone, and she has excess MSH stimulation. So everything else is within normal. Last menstrual period 2 weeks ago. Pelvic exam, nothing. Okay, pigmented skin, creases of elbow. Okay, not supposed to have that, but this is where we're saying again, MSH. Pedal pulse is moderate weak, dehydration. Strength is normal, intact, normal gait. Everything else is normal except for those three variables that we're talking about. Loss of aldosterone, low blood pressure, lack of cortisol causes the response to MSH, MSH pigmentation, right? So, wow, that's a lot of lab values. Okay, we're almost to the end of this. 126 on the lower end because we already know she's hyponatremic from lack of aldosterone. The sodium potassium pump is actually, so if you guys ever had to review this, which you haven't in a while, but the sodium potassium pump is the reason why you can do the exchange of the kidney. And aldosterone triggers or activates that pump. So it causes salt to be taken into the body and for you to dump potassium. So if your aldosterone is normal, salt will be within normal range and it'll maybe be higher, and potassium will be low. So look at this, it's the opposite. We have low salt and high potassium, telling me that aldosterone is not working well. Within normal, oh wait, no, actually that's elevated, 22 to 26. So let's see what's going on. So BUN, within normal, pushing to the higher limits, but not outside the range that we're looking for. Glucose, glucose, is it high or low? Remember, cortisol is like a sugar. It's a glucocorticoid. So high cortisol means high sugar. Low cortisol means low sugar. So her sugars are probably going to be on the lower side. It's less than the 70. We know that because cortisol is low. So we got phosphate. So we're looking at kidney function, whether or not she has any problems with that. Uric acid, maybe trying to rule out gout, right? Hemoglobin, hematocrit on the lower end. But we know that already. That's a other compounding factor. That was the pernicious anemia. She's anemic because she has vitamin B12, right? Vitamin B12 issues. So cyanocobalamin to replace the B12 and help her alleviate the anemia. Okay, let's see. Platelet within normal, white blood cells within normal. I don't know why they keep putting that. Usually it's like 60, 30, 6, 3, 1, but okay, we look at the ranges. No liver dysfunction. We're trying to rule that out, right? She is not malnourished. That's what they're trying to rule out as well. I believe, yeah, that's within the normal ranges. Cholesterol is a little bit elevated. Want it under 200, right? And then triglycerides, yeah, borderline too. So iron, we're trying to maintain that. Trying to rule out TSH. So we're going to skip this just because we know that we're trying to attribute it to the aldosterone and the cortisol, right? So Addison's. So rapid ACTH stimulation, imaging of abdominal scans for bilateral atrophy of the adrenal glands. Boop, boop. That's right. That's it. Okay, that's what we're looking for. So here we go. Here's your numbers, aldosterone. So we're essentially, you guys don't need to numbers. Just remember low, low. So I know that I have destruction of that guy. Okay, I could do this. There's actually some enzymes and some like substrates that go through this pathway. We don't need to know it, even though from my undergrad class I kind of make them do it. So there's 21 beta hydroxylase, or 21 beta hydroxylase is an enzyme, and since there's an antibody against that enzyme, it's attacking these two pathways. So you have a lack of aldosterone and a lack of cortisol, and it's just confirming it this way. Okay, so other than that, that's it. Yay.